Hypertension, it is defined as sustained increase in arterial BP, systolic BP 140 mmHg, or diastolic BP 90 mmHg, at least 2 reading on separate occasions, 4 hours apart. Classification, AHA classification, JNC8 classification, JNC8 goals, hypertensive crisis, it can be divided into 1. Hypertensive urgency, it is defined as SBP 180 mmHg and DBP 120 mmHg without end organ damage. 2. Hypertensive emergency, it is defined as SBP 180 mmHg and DBP 120 mmHg with end organ damage. Malignant hypertension, it is defined as when BP rises rapidly and severely DBP 140 mmHg, causing fibrinoid necrosis of vascular wall, ultimately resulting in encephalopathy, stroke, cardiac failure, renal failure with proteinuria, papilledema and retinal hemorrhages. Resistant hypertension, it is defined as uncontrolled hypertension despite of 3 or more antihypertensive medications of different classes, and a need for 4 or more drugs to achieve target BP. Refractory hypertension, it is defined as uncontrolled hypertension despite of 5 or more antihypertensive medications of different classes. Isolated systolic hypertension, it is defined as hypertension secondary to stiffness of medium and large size vessels, i.e. macrovascular vessels, leading to increase in SVR, and wide pulse pressure, 65 mmHg. Commonly affected people, 50 years of age. Isolated diastolic hypertension, it is defined as hypertension having systolic BP 130 mmHg and a diastolic BP of at least 80 mmHg. Usually occurs in younger patients, 50 years of age, and is an important marker of coronary heart disease and mortality. Essential hypertension, it is defined as hypertension which has no identifiable cause. It is also known as primary hypertension or idiopathic hypertension. Secondary hypertension, it is defined as hypertension due to specific underlying disorder. White-collar hypertension, when blood pressure reading at a healthcare provider office are higher than they are in other settings such as at home, cause of which is usually anxiety. Pathophysiology of hypertension. 1. Abnormal baseline elevation of CO and SVR or both. 2. Over the course of disease CO becomes normal and SVR becomes abnormally high. 3. Chronic increase in SVR, i.e. afterload, leads to concentric left ventricle hypertrophy which in turns lead to 4. Diastolic dysfunction. 5. ANS and renin-angiotensin system are the culprit. End organ damage associated with long-standing hypertension. 1. CVS. A. Left ventricular hypertrophy, B. Left ventricular diastolic dysfunction, C. Left ventricular systolic dysfunction, D. Myocardial ischemia infarction, E. Arrhythmia, F. Congestive cardiac failure, G. Abdominal aortic aneurysm. 2. IA. Hypertensive retinopathy, B. Arteriosclerotic retinopathy, C. Retinal hemorrhage. 3. Renal. A. Nephropathy, B. Progressive renal failure, C. Albuminuria. 4. CNS. A. Stroke, B. Transient ischemic attack, C. Subarachnoid hemorrhage, D. Cognitive dysfunction, E. Dementia. Antihypertensive therapy. Drugs, diuretics. 1. Loop diuretics, name, furosemide, bumetanide. Mechanism of action. 2. Thiazide diuretics, name, hydrochlorothiazide, ethacrynic acid. Mechanism of action. 3. Potassium-sparing diuretics, name, spironolactone, amiloride. Mechanism of action, side effects of diuretics, antiadrenergic agents, peripherally acting. 1. Alpha blocker, A. Non-selective, Greek letter alpha 1 and Greek letter alpha 2, phentolamine, reversible, phenoxybenzamine irreversible. B. Selective, Greek letter alpha 1, prazosin, doxazosin 2, Greek letter beta blocker, A. Non-selective, propranolol. B. Selective, A. Ametenolol, metoprolol. C. Greek letter alpha and Greek letter beta blocker, carvedilol and labetalol. Centrally acting drugs, A. Clonidine, B. Dexmedetomidine. Endothelin receptors blocker, Basentin. Direct vasodilators. 1. Calcium channel blockers. 2. Hydralazine. 3. Nitroprusside. 4. Nitroglycerin. Calcium channel blocker classification, dopamine agonist, Phenoldiprem mechanism of action, DA1 natriuresis use, for hypertensive emergency and infusion form ACE inhibitors, captopril, enalapril, ramipril ARB blocker. Losartan, valsartan mechanism of action, side effects, management protocol, preoperative evaluation. 1. History and systemic review. 2. Etiology of hypertension, either primary or secondary, along with severity, current therapy and end organ damage as discussed above. 3. Correct the deranged electrolyte secondary to drug therapy as they predispose to arrhythmias. 4. Formulate the plan. 5. Postpone elective surgery if arterial pressure exceeds 180 mm Hg, systolic 110 mm Hg, diastolic 6. Presence of end organ damage increase perioperative risk. Further investigations are required in addition to control of BP. 7. Patient with stage 1 and stage 2 hypertension without end organ damage can proceed for elective surgery. 8. Continue all antihypertensive agents till day of surgery, other than ACE/ARBs, for which there are two school of thoughts. One says discontinue 24 hours prior to surgery to prevent cardiovascular instability, other school says continue. 9. Pre-medication should be done with benzodiazepine. 10. Maintain IV line and optimize hydration before induction. 11. Goals of BP before surgery should be according to JNC 8 intraoperative monitoring. 1. ASA standard monitoring should be applied, which include ECG, NIBP, pulse oximetry. 2. ECG. 5 leads, with special attention to lead VN2. 3. NIBP or invasive A-line, if suspecting wide swings in BP. 4. Other monitors, pulmonary artery catheter, CVP, Foley's as required. Induction. 1. Make sure IV line is passed, with fluid running. 2. Monitors applied. 3. All emergency drugs and emergency trolley with difficult airway equipment is ready. 4. Anesthesia machine is checked with oxygen supply. 5. Start pre-oxygenating the patient with proper size mask. 6. Blunt the laryngoscopy response with any of the following drugs: esmolol 0.5 mg kg, remifentanil 0.5 mg kg infusion, C, fentanyl 5 mg kg D, lignocaine 1.5 mg kg E, propofol 0.5 mg kg F, alfentanil 20-30 mg kg 7. Start giving induction drugs in titrated doses along with muscle relaxant, choice of which depends on elective emergency, and analgesic agents. 8. Minimize the time for laryngoscopy to 15 seconds. During this time you will encounter abrupt increase in BP, which may be due to unopposed Greek letter alpha actions, if person was taking B blockers. 9. If you encounter hypotension following induction, do the following: a volume resuscitate B, vasopressors including phenylephrine, adrenaline and top-up doses. 10. Once the airway is secured with correct size tape it, and put the patient on ventilator, making sure inhalational agent is turned on. Maintenance. 1. Keep the inhalation agent turned on, making sure patient is having adequate depth. 2. Keep patient paralyzed with use of muscle relaxant. 3. Provide adequate analgesia. 4. Monitor strictly. 5. If intraoperative hypertension, rule out the causes by making differential diagnosis: inadequate depth B, pain C, hypoxia D, hypercarbia E, thyroid storm F, pheochromocytoma G, Cushing's syndrome H, raised ICP. 6. Stop the surgery and treat the hypertension with available agents and send labs such as TROP-I, 12-lead ECG, etc. 7. If intraoperative hypertension, treat the patient with vasopressors and make differential diagnosis: hypovolemia B, obstructed venous return C, increased thoracic pressure D, anaphylaxis E, embolism F, sepsis G, cardiac failure H, DIS. Arrhythmias recovery. 1. Give lignocaine B blocker before extubation. 2. Make sure patient is hemodynamically stable before extubation. 3. If patient is hypertensive after extubation, treat the cause by making differential diagnosis: incisional pain B, emergence excitement C, hypoxemia D, hypercarbia E, full bladder F, hypothermia G, hypervolemia H. Chronic medication withdrawal.